For almost 80 years, Blue Cross and Blue Shield of Rhode Island has been proud to partner with community organizations to promote a healthier Rhode Island. Blue Cross and Blue Shield of Rhode Island. It takes a team.
The opioid crisis has touched every corner of the country, an epidemic that is being called the deadliest public health crisis in U.S. history, and it's happening right here in our backyard. Hello, I'm Kim Keogh, and welcome to this Rhode Island PBS special. Rhode Island has faced many crises over the years, but few compare to the opioid epidemic that has so many Rhode Island families under siege. With the 10th highest overdose rate in the country, down from the 5th highest in 2015, local leaders have taken hold of the reins, and the Ocean State has emerged as an innovator when it comes to addressing the problem. Governor Gina Raimondo created the Overdose Prevention and Intervention Task Force, made up of scientists, professors, and thought leaders in addiction. But even with all that brain power dedicated to the fix, they've only just begun to understand the grip opioids and other illicit drugs have on our community. During the next 50 minutes, we'll introduce you to people who are working tirelessly to save lives, from first responders to emergency department doctors, and a family that has suffered the unimaginable. We'll also speak with healthcare experts and legislators who are working against the clock to create new policies and solutions to this deadly epidemic. Rhode Island is known for its scenic beaches, iconic lighthouses, and a vibrant capital, alive with arts, renowned restaurants, and bustling commuters. But just underneath the surface, the opioid epidemic has taken hold of our communities, killing more than 1,600 Rhode Islanders in the last 6 years. On this day, our cameras are in Providence, one of the hardest-hit communities in the state.
That's Rescue 7, Engine 7. Respond to 99 Kennedy Plaza. Filming by bus stop Y Yankee. For a male that is unconscious, he has fallen off the bench.
You know his name or anything? Hey, what's his arm? What's his arm? Okay. Yeah, just throw in the truck, please.
Roll right up there behind you. Roll. What's that? Put him through the line.
1746.
Put it down close. He's starting to go out. Put that run.
They said near the subway. This ain't near the subway. Is there somebody else down over there or no?
No, good line.
All right, sir, come on.
Right there. There we go.
There we go.
Hold it. Yep. Oh, relax. 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 Relax.
Yep.
Take go.
Did you do any drugs today?
No, I just got really hot and I passed out.
All right, because we gave you Narcan, you woke right up. We're here to help you. All right, did you do a little bit of heroin or a lot?
Just a little bit.
How long did you do it? An hour ago, half hour ago?
Yeah, like an hour ago.
Okay, all right, that's all.
The drug's so powerful where people, if they have $10 in their pocket, they'd rather buy the drug than go buy their kids' food, their baby's food. They'd rather buy the drug. I was in a house once, and a guy was basically dying in front of his 2 kids. We went to give the Narcan to save his life, and as I was giving it, he actually was fighting me like this not to give it because he wanted his high. He'd rather chance getting high than lose his life than me give Narcan to save his life. And that's when you start knowing how powerful this drug is. And his 2 little kids are watching the whole thing.
Rescue Captain David Palumbo has been a Providence firefighter for 27 years and says overdose runs like this one are a daily occurrence. And in the past 15 months, those calls have doubled.
A lot of our overdoses are the same couple spots in the city, but definitely it could be a next door neighbor. It could be the guy who cut your hair. It could be a dentist. It could be a school teacher. This drug has no friends, and it's very easy to get addicted to it. And once you're addicted, it's very hard to get off it. Now anybody could do it, and everybody is doing it.
According to medical experts, America's addiction to opioids began with prescription drugs like OxyContin, Percocet, and Vicodin, which are potent pain-relieving medications and are typically used to treat patients with severe pain or to manage acute pain after surgery. The downside, they are highly addictive and expensive. Once addicted, many turn to less expensive illicit drugs like heroin. But in the past several years, another drug has made its way to the streets and is more powerful and deadlier than anything we've seen before.
They don't even know they've been doing it, to be honest with you. A lot of them we pick up and we revive them, they have no idea what they did. They're buying the drugs on the street, they're buying it from people that they don't know, and the end result is if we don't get them in time, they're going to die.
He's talking about fentanyl, a highly potent opioid which experts say is 100 times stronger than morphine and 50 times stronger than heroin. And drug dealers are mixing it with everything from pills to heroin and even pot. According to Prevent Overdose RI, an organization that tracks the opioid epidemic in Rhode Island, the number of overdose deaths related to illicit fentanyl is on the rise and has increased by almost tenfold since 2009. In 2016, over 50% of overdose deaths involved illicit fentanyl. With the arrival of this powerful drug, rescue crews take extra precautions.
When we get these runs now, we're wearing these black gloves, which shows if the chemical's in there, it would show on the glove. We're being a lot more cautious. We're not running right in there now. We got to kind of take a step back and make sure the scene's safe and what we're doing is the right thing. Definitely the last year or so, we've been really getting, because of what's going on with that drug and how potent it is, we are being a lot more cautious with this stuff.
As you can imagine, the emotional toll runs high when your job is to revive an overdose victim on a mix of fentanyl and heroin, a deadly combination that is seen day in and day out. But Palumbo says it's something he has learned to deal with.
There's definitely emotion runs into this job. You try and shut it off. You try and, there's a difference between, your home life and your work life, and you try and separate it. But when you go on these runs and families are affected, when parents overdose in front of their kids, it definitely affects you. It's hard to just turn it off at that second.
Palumbo says he has gone on so many overdose runs in the last year, he has lost count. But Prevent Overdose RI has been meticulously keeping track. From February 2016 to March of 2018, there has been more than 900 emergency department visits for overdose that came from Providence alone. Overall, Rhode Island's emergency departments have had more than 3,450 ED visits for overdose during that same time period. To put that in perspective, that's an average of 129 visits a month, or 4.2 every day. And for Dr. Francesca Bodwin, an ED doctor at Rhode Island Hospital, it has become routine.
This is an everyday occurrence. This isn't a Saturday night problem. This is a 24/7, Tuesday at 8 a.m., Thursday at 3 p.m. problem, and it was not like that before.
Bodwin has been at Rhode Island Hospital for 12 years, and I asked her if she and the nursing staff ever experienced compassion fatigue from the sheer volume of overdose victims in the ED.
I think it's hard. The opioid epidemic, opioid overdoses are particularly challenging because it predominantly affects young people. It's sudden, it's unexpected, and so I think the emotional, the human part of that is real. And I think it impacts us much like other things that afflict young people or sudden unexpected, like car accidents, for instance. The idea of compassion fatigue is something to be aware of and in tune to, and to not let that happen. With this problem, we have to be persistent, we have to be vigilant, and we can't be fatigued, because this is a long battle.
That fatigue Dr. Bodwin talks about is difficult, especially when she sees the same faces time and time again. Bodwin says getting someone with opioid use disorder into treatment is complex and riddled with challenges, such as withdrawals, family commitments, or no support. So while the moment immediately after an overdose is an opportunity, not everyone is going to take that opportunity in the ED.
Yes, it's frustrating. I mean, I think it's frustrating in the same way that we see people come to the emergency department with other chronic health conditions. We want people to get better. We want them to recover. Nobody wants to see people come in with a repeat overdose. But you can't let that frustration be present in your work. It's a matter of offering what we know is the right things based on the best available evidence and research we have, and repeatedly offering them in the hope that Each time things are offered, it's building a bridge, and one day somebody's going to walk over it.
We spoke to one young man who took advantage of that opportunity, but not before enduring years of active addiction. Gary Zeman went from using prescription pills to snorting and injecting heroin in a relatively short time. He checked into rehab facilities only to relapse multiple times. Eventually, he had had enough. Gary has been in active recovery for more than 3 years and is putting the pieces back together.
Today I'm a father, I'm a son, I am a boyfriend, just things that I've never dreamed of being in the past 3 years, I am.
The 28-year-old Zeman grew up in Cranston in an upper-middle-class home with his parents and 2 younger brothers, Tyler and Ryan. Life was good. They went on family vacations, went fishing, and genuinely enjoyed each other's company. But shortly after high school, things changed. Tell me about that first experience with opioids.
I took that Vicodin because I had a migraine, and as soon as I took it, about 5 minutes later, I just got this overcoming sense of just warmth and just happiness. It filled some kind of void, I don't know, but I mean, I was in love, you know?
Gary says within about 30 days, he was completely hooked on prescription pills. And not long after that, he made the switch to heroin.
It didn't take very long, I'd say within the course of 1 year.
And it came from the most unlikely source.
My younger brother, he just introduced me to it. I was in withdrawal one day, and I didn't have a choice, you know? When you're in active with withdrawal, you don't have a choice. You're gonna use, you know? And I found out that it was much, much cheaper. It was a better high, and I could stay high longer.
What makes this story unique is that all 3 brothers became addicted to heroin and other opiates. Their family pulled apart by drug addiction, a scenario far beyond belief for their mother, Maureen Kershaw. She recalls the day she knew something was wrong with Gary.
So I was at work, and just, I don't know if it's mother's intuition, but I said, something's wrong. I know, you just tell, you know, something's wrong. I'm going home. So I had the ability to just leave. And when I got home, Gary's car was there, so I knew he wasn't at work. I thought Gary was very depressed. That's all I thought. I said, Gary's depressed. When I walked in, Gary was laying on the couch, and he had a blanket over him, and he was shivering, and he just looked awful. His eyes were sunken in, you know. His eyes were almost just lifeless even. And so I went and I sat next to him. What's the matter? Please, you don't have to go through this alone. I'm here for you. There are people who can help you. All along, I'm thinking he's going to say, Mom, I'm depressed, which is going to break my heart. But instead, he says, Mom. And I said, yeah, honey. And he said, I'm a drug addict. And I never, ever expected to hear that. I mean, that was like a brick just smashing me in the side of the head. And I had to sit there and look at him, and, you know, it was surreal. And I'm sitting there and I'm saying, well, he's not depressed. He just said that he's a drug addict. What's that? What do you mean? Not my Gary. And then he started crying. He was crying and crying, and I cried. We held each other.
With 3 sons in active addiction, Maureen used to question whether or not she did something wrong, but now knows she provided them with one of the most important things.
They were loved and cuddled and sang to every second, rocked. We had patience. We loved them. We loved them with unconditional love, and I still do. Even with everything that happened, there were times I'd say, I don't like you right now, or I don't like your behavior, but they always knew that I loved them.
When did you realize that Tyler was using?
I knew, oh, okay. One time I went under his bed to vacuum, and I hit something with the vacuum. So when I went underneath the bed, I found a picture frame with the picture taken out, just the glass. And I found one of my knives, like a very sharp knife, on top of the glass. So I knew there's no reason why a picture frame, a glass, should be inside under his bed with a knife on top. I didn't know, but I assumed. And remember, by now, We have Ryan who's using, Gary who's using, and now Tyler. And I didn't want to be in denial. As much as you don't want to face it as a parent, you have to.
Eventually, all three boys, Gary, Ryan, and Tyler, made their way to a treatment facility in Florida, experiencing multiple relapses along the way. But on April 21st of 2017, Maureen received a phone call notifying her that Ryan had died of an accidental overdose. He was 26 years old. The year since Ryan's death has been a difficult one, but Maureen tries to remember the good things.
Ryan would always send me pictures of a sunset. He loved sunsets because he always said, "Ma, you taught us that the most wonderful things in life are free." So he would always take a picture of a sunset and he would text it to me. And I have the picture of what his very last sunset that he saw. And then he took a picture of himself, and I wrote that night right before he died, I said, "Are you okay?" He didn't look right. And I said, "You okay?" And then I received the text message a little while before he died. And he said, "Yeah, why? LOL." When he got back on December 28th, he called, "Mom, I had such a great time at Christmas. I love you so much. I love Bob." That's his stepdad. "Thank you again. I'll talk to you soon." And I had that voice message for a long time. And about 4 months ago, I don't know, I did an update to my phone and I lost that voice message. So now I don't even have Ryan's voice. He's gone forever.
According to Gary, Ryan thought he was buying heroin the night he died. But when the autopsy report came back, it showed that there was only fentanyl in his system. Since that day, Maureen and Bob are taking life one day at a time. They relax outside overlooking the pond where they used to sit as a family.
Love you. You're the best.
Gary is doing well and working with others who struggle with addiction at Community Care Alliance as a peer recovery specialist.
A lot of people are afraid of coming off of heroin because of the withdrawals, but I would highly, highly encourage you to just do it. It's just well worth it, you know. I've done it multiple times, and eventually I just had enough. You know, I kind of had this epiphany. Wow, you mean if I don't do heroin, I'm not going to end up back in a treatment center? This is great, you know. And eventually I just had enough. I wanted some like stability in my life. I wanted to be able to have a family and to just live, you know. To keep it really, really simple, and not to sound like a dare officer and say, "Don't do drugs, kids," but seriously, you just can't even try opiates once, because you're playing Russian roulette. You're gonna take that pill, or you're gonna do heroin, and there's a 50-50 chance whether you're gonna hate it and never want to touch it again, or you're gonna love it, and it's gonna fill that void. It's gonna just overcome you with warmth and happiness, and it's just all an illusion.
But that illusion is very real for many families. The opioid crisis is an issue that legislators, doctors, and experts in addiction are taking seriously and working tirelessly to find ways to overcome. Senator Josh Miller is a member of the National Task Force of State Legislators that has been charged with identifying solutions to the addiction crisis. He worked closely with President and CEO of Hasbro, Brian Goldner, who lost a son to addiction. Together, they have shaped Rhode Island's opioid addiction policy. In 2016, they pushed for reform in emergency departments statewide.
It's called the Perry-Goldner Act because the two families had sons who died of overdoses, and the circumstances surrounding those cases applied to what happens in emergency rooms. Both had had several overdose situations that led them to engage in the emergency room. There are several components to it that we feel, since it's passed, have led to better protocols and better outcomes in emergency rooms.
One of those protocols is to receive a patient's consent to call their emergency contact while in the ED. Had the Goldners known of their son's addiction and his multiple visits to the ED, the thought is that they could have intervened and gotten their son Brandon into treatment. Another protocol to the Perry Goldner Act is providing a peer recovery specialist in every ED setting across the state. As we mentioned earlier, Gary Zeman is one of those specialists.
I like to keep it really, really simple. I don't want to bombard them with, necessarily like my whole history. I'll just introduce myself. They'll learn a little bit about me. I'll learn a little bit about them. And I'll figure out where they're at. Have they been to treatment in the past? Is this brand new to them? Have they never detoxed in their life? Everybody's story is completely different. And not everybody that I work with I can help, I wish I could help everybody, but some people want it one day, and then a day later, they're just afraid.
Peer recovery specialists receive intense training in behavioral intervention and to provide that needed access to care. Specialists are available to the ED 24/7 through community organizations including Anchor Recovery, Kodak Behavioral Health, and Community Care Alliance, among others. Typically, peer recovery specialists sit with the patient and try to work out a strategy for treatment. And while specialists are effective, it's estimated that only 50% of the people who come to the ED for an overdose take advantage of this resource. Luckily, more pieces to the puzzle have been put in place.
10 years ago, if somebody came in with an opioid overdose, once they were stabilized from that acute problem, we had very little to offer them. Now you can see a peer recovery specialist, you can see a social worker in the emergency department, we can link you to treatment, sometimes on a next day basis. We can provide access to medication-assisted treatment. These are things like Suboxone and Vivitrol. We can actually do that in the emergency department. We can provide naloxone, which is a life-saving antidote for opioid overdose, and teaching with naloxone. So we dispense kits for free to anybody that wants them. In particular, we offer them to patients that have come in with an opioid overdose. So that is a whole complement of things that we didn't have 5-10 years ago.
Much of what is now being offered in local emergency departments is attributed to the transformative legislation by Senator Miller. Another important component to solving the opioid epidemic is Governor Gina Raimondo's Overdose Prevention and Intervention Task Force, a group of local experts that began communicating and coordinating their efforts in 2014. One of the lead experts is Brandon Marshall, an associate professor of epidemiology at Brown University. He was instrumental in creating the strategic plan.
One thing that became clear very quickly is that there was a lot that we could propose and a lot that we could do. So we wanted to be strategic and propose maybe like 4 things that we felt would have the biggest immediate impact. So myself, being from Vancouver, I looked to a policy document that was generated there that focused on what's called a 4 pillars approach, where you invest in 4 pillars, and the idea is that that approach can have a bigger impact than if you put all your eggs in one basket or spread efforts out in a too diffused manner. So that's where I got some inspiration, and that's, I think, in part where we ended up with a 4-pronged strategy to address this epidemic in Rhode Island, which is focusing on prevention, treatment, rescue, and recovery.
Addressing prevention, one of the 4 pillars in that strategic plan is the PDMP, a tool that was rolled out in 2012 to help combat the epidemic, where many believe it began, prescription drugs. Dr. James McDonald is Rhode Island's medical director for overdose prevention and a member of the task force.
The prescription drug monitoring program is a tool. It's a database. So anyone who prescribes a controlled substance has to be registered by us at the Department of Health, and then they can access this secure database, and they can see what controlled substance prescriptions someone has received in the past. That's important because they can see what folks have at home.
Dr. McDonald and his team are at the forefront of healthcare policy and statewide initiatives in the fight against opioid overdose deaths, and he believes there are other options to treating pain.
One point I want to underscore is prescription opioids are the worst clinical tool we have in the toolbox to treat chronic pain. We have other tools. We have anti-inflammatory medicine. We have availing ourselves to other disciplines too. Physical therapy, chiropractic medicine, acupuncture. These are different resources we can offer our patients that is a far safer option. And, we also need to underscore that although chronic pain is uncomfortable and it's affecting our life, we have to find a way to function in our life with some level of chronic pain that's far better than becoming dependent or addicted on a prescription opioid.
According to the Rhode Island Department of Health, in September of 2016, the PDMP received 100% enrollment by providers who are authorized to prescribe opioids and other potent medications. Dr. Bodwin is an advocate of the program.
The prescription drug monitoring program is a means by which I can access recent prescriptions, generally for the past year, for patients that I might be considering prescribing opioids to. I can see if they've gotten other controlled substances. That means opioids, things like Percocet, Vicodin, also benzodiazepines. And that might help me decide of whether or not it's safe and appropriate to give someone an opioid prescription. It also lets us potentially detect problematic behavior, visits to multiple providers, multiple prescription for opioids, multiple different hospitals, and so it's also an opportunity to talk to patients about that.
Dr. Bodwin says in general, the prescribing of opioids has gone down and believes the PDMP has influenced that decline. However, she also believes it's a combination of many programs that have been implemented throughout the state. She says prevention is a start, but the primary goal is simple. It's about saving lives. Many communities now hold training sessions to teach the general public how to administer the life-saving drug Narcan.
We give you this kind. It's a liquid that you're going to draw up with a needle and syringe and inject it. We want to get Narcan, naloxone into the hands of as many community members as possible to try and help reverse some of these overdoses, prevent these overdose deaths from happening. Our ultimate goal is to keep people alive long enough that they can get to the point where they're ready for sustained recovery. Recovery, we know, is a process that is often prolonged. It often involves relapse, but people do recover from opioid dependence and do come out on the other side of that and do achieve sustained recovery. We want to give people the opportunity to achieve sustained recovery, and we do that by trying to keep them alive in the meantime.
The day we were there, 8 people showed up for training. Doro says people attend because they are worried about a family member, a friend, or a neighbor. Since 2012, an estimated 18,000 naloxone kits have been distributed statewide between community programs, pharmacies, and hospitals. Medic, Doro has administered the drug more times than he'd like to remember.
I wouldn't want to meet the person who becomes numb to the devastated parent when they discover their child has overdosed and died. That is something that you don't really get used to as a healthcare provider. You learn how to deal with it, you learn how to do your job and how to move forward with your own life, but it sticks with you. It's something that's hard to witness, hard to be a part of, hard to be involved with. It's hard to comfort that person. You can't comfort that person. You can be there for them, you can be supportive, you can listen, but you can't bring their kid back. That's hard.
The hope of all the programs being implemented to fight this epidemic is to save lives and to get people into recovery. 24-year-old Ryan Dennis has struggled with opioid use disorder for many years. It eventually caught up with him, and he was sent to prison.
I ended up getting arrested that night. The cops came to the hotel door and had a bench warrant out for my arrest.
While in the ACI, he participated in one of those programs and is now in active recovery.
When I was younger, my dad left me, and then we reunited around 18 years old, when I was 18. So we had a lot of lost time, and we did drugs together, and I think we were trying to make up for that lost time, but in the wrong way. I was using Oxycontin, Percocets, Clozapines, anything, any pill, really, prescription pills.
How are you getting them?
Off the streets, yeah. Never got subscribed to, but family members, which is sad, but if they got it, they'll help you out. They don't want to see you sick.
Because of his addiction to pills, Ryan began stealing from friends, family, and beyond.
I've been to jail 3 times.
For what?
All of them were pretty much for stealing. And like I was a thief, like big time. Like going to grocery stores. They're all misdemeanors, thank God I didn't get no felony. I should have, but I didn't. But so they were all drug related too, though, because if it wasn't for the fact that I was on drugs, I wouldn't normally do that, you know. But because I was intoxicated, it led me to believe I could get away with certain things. Is this really gonna be my life, you know, for the rest of my life? Without the program, obviously, you know, I might still be in it, but like, because I had the resources with me and I had people I could talk to, I realized I'm 24 years old, you know, I don't want this to keep going on the rest of my life. This is the 3rd time it's happened. Like, when am I gonna finally call it quits, you know? And this time, because the program was there, it was a big help.
The program Ryan is talking about is the Medication-Assisted Treatment Program that was implemented in Rhode Island's prison system in 2016. The MAT program is groundbreaking, the first of its kind in the country to provide all 3 FDA-approved medications, Suboxone, Vivitrol, and Methadone. According to the Department of Corrections, 25% of the people who come into the prison system have an opioid use disorder. In 2014, 60% of all fatal overdose victims in Rhode Island had been incarcerated in the 12 months leading up to their death. Dr. Jennifer Clark is the medical program director at the Rhode Island Department of Corrections, and she says she wanted to implement the program for years but couldn't get the necessary support. That changed under the Raimondo administration.
Funds were about $2 million. That came from the governor's task force. I think Governor Raimondo, you've really got to give her a lot of credit, because not every governor would be willing to take a risk like this. But she really saw overdose deaths as a tragedy where there are solutions, and really dedicated herself to finding those solutions and putting the investment behind those, really to solve the problem.
Because of the treatment across our correctional system, I can announce that overdose deaths for recently released inmates decreased by 61% since we started this program.
You're setting precedents here. And how did you put that process in place, and how difficult was that?
We just took it piece by piece. We decided we wanted to make it a comprehensive program. So that meant we wanted to touch 3 populations. People that were coming in on MAT. In the past, they'd been taken off. So first of all, we stopped taking people off of treatment, and we continued them on their treatment. Second population was people coming in who were withdrawing, and before we would just give them treatment for their symptoms, but we changed and we provided MAT to people coming in and feeling ill.
The third population Dr. Clark and her team targeted for the MAT program were those inmates preparing to be released into the community. Clark says they are the most vulnerable.
The reason it's important to provide it to that population is we know that that population is the most likely to die of an overdose, that their tolerance has gone way down, and if they use the same amount that they were using before they came to prison, they will easily overdose and could die.
Why is it that they need MATs at that time if they haven't been using at all?
So the brain has changed. So as I said before, the brain has basically remodeled. So even if somebody's away from the drug, it doesn't mean that all of the changes, that the brain just goes back to normal. So that when somebody gets out and there are triggers, they're going back to the same neighborhood, they're seeing the same people, they will still have those cravings.
With funding in hand, Clark was able to bring Kodak Behavioral Health to set up medication dispensing protocols within the prison. Kodak is the largest nonprofit outpatient provider of treatment for opioid use disorder in the state, and its nursing staff pours, packages, and labels each medication in a highly secured area of the prison. Those inmates participating in the program are taken to this room to receive their medication. Because Clark is setting the standard, she's always looking to improve the process.
We're moving towards giving them more in the morning than in the evening, because for people who take it at night, it tends to wake people up. Often people think it's an opiate, so it should make them tired, but it doesn't, because it's being used as a treatment. It's not being used illicitly. So having that treatment in the morning helps people so they sleep throughout the night, and they feel better, and they can be more engaged in the other parts of their treatment, such as the groups, individual counseling.
Approximately 2,100 inmates have participated in the MAT program since it began in 2016, which also includes counseling and group therapy sessions. And when an inmate walks out that door, their treatment doesn't end. Discharge planners at Kodak carefully coordinate medication schedules and counseling so recovery can continue without interruption. The staff helps with health insurance coverage, transportation to and from one of its 7 locations so patients can receive treatment. They also help with housing and even jobs. Ryan has been out of prison since February of 2018 and is now employed at a local hotel.
Kodak's changed my life. I've been with Kodak for like 3 years now, or 3 or 4 years. In and out though, but this time's different. We all know that. But yeah, without that, I wouldn't have the support. So it's definitely good to reach out to people and try to find a program if that's what you need, or just a counselor, somebody to talk to. It feels great, it really does, because now I know I'm gonna be able to financially support myself, which is something I haven't been able to do in a while. And without spending it on drugs and alcohol, I'm gonna be able to save it.
There are a few programs in the country that provide one MAT drug or another, but it's not offered to the entire population. The ACI is the only program that makes available the full suite of MAT to every individual in need, coming in or leaving the correctional system. A year into the program, Dr. Clark had enough data to prove that they were onto something. What they found was, in the first 6 months of 2016, prior to the MAT program, 26 people died of an overdose who had been previously incarcerated. During that same time period in 2017, with the program in place, only 9 of the overall deaths were individuals who had been in the ACI. That's a relative risk reduction of about 60%.
So it's quite significant that the overall state decrease in mortality is probably driven mostly by the incarcerated population getting treatment and going out and being safer, being healthier. I think it's going to be difficult not to provide MAT with the results that we've had and the mortality rates that there are in the community. It's a serious medical condition, very high mortality. We've got a treatment that works. We've got 3 treatments that work. We really have to stop judging people and just provide treatment. The stigma, the judgment, it doesn't help. It doesn't help anyone recover. What helps people recover is medication, support, counseling, behavioral therapy. Those things help people recover.
One person who understands the importance of therapy and counseling in the recovery process is Michelle Taylor. She's the Director of Outpatient HIV and Reentry Services at Community Care Alliance in Woonsocket.
One of the things that we're finding out as we're trying to implement these new opioid centers of excellence is that because of the nature of this addiction, people do need a lot more support. So, residential treatment, intensive outpatient treatment, these are all levels of care that clients will often have to work through before they are able to sustain a period of recovery and an outpatient level of care.
Taylor says that as a whole, the state is making strides in combating this disease, but there are still many gaps. She recalls a client who almost fell victim to one of those gaps.
What had happened is that she had actually run into one of our case managers in the community, and that was enough, that contact was enough to bring her back in. And she had relapsed, and she was prostituting to be able to pay for her drugs. And she said, I'm ready. So we called to see if we could get her into a detox facility that day, and there was no bed available. So we were able to get her a bed for the following day, but one of the conversations we needed to have was, do you have some heroin at home? And the answer was yes, I do. And so we had to talk about, are you going to use it? Yes, I probably will.
Immediately, Taylor went into what clinicians call harm reduction mode. She made sure her client had a prescription for naloxone and that someone would be with her that night who could administer the drug if necessary.
This story does have a good ending. She did show up the next day, because very frequently people don't. They use and then they're lost again.
Dr. McDonald, as we mentioned, is part of the task force, and we asked him what he thought of that story. Do you think the lack of beds in treatment centers is a problem?
I don't know what the individual breakdown in this case is, but I do know the physicians I'm talking to at Kent, at Lifespan, and at Butler want the patients. I know the Center of Excellences across the state, Kodak, Kenwin, are looking for patients. But we might run into a situation where humans interacting with humans may not be always as smooth, but we shouldn't have these problems. But I have a feeling there's people across the state who are listening to me right now who said, we would have pulled that patient in. We wanted that patient. We would have seen that patient that day or the next day. We would have found a way. So I think that psychologists had some options that might have been a little bit safer for the patient, because we can't ever encourage anyone to use their heroin.
People can be very well intended, but if we don't understand the reality of what's going on with our clients, if we don't see them in the day-to-day, we're not going to be able to come up with solutions that really work. So breaking down those barriers and having those conversations is absolutely essential, because if you have people who are in a position of creating policy and they don't understand the reality of the lives of the clients that we're working with and the reality of the work that we're doing, we're not going to make a significant impact on this crisis.
Taylor also believes there is one barrier that looms large in combating the opioid crisis, and that's stigma, not only in society, but in the healthcare system itself.
We need to change the way that we view addiction. As long as we see addiction as a character flaw, as long as we see it as a failure of will, we are not going to make a significant impact. Because the Centers of Excellence are so tightly bound to the idea of medication-assisted treatment, because it works, we think that's a significant factor, that stigma around MAT, that if you are on MAT, you're still not clean. You're still, and the word is dirty. They use that word dirty, right? And we're trying to get rid of that language, because we wouldn't tell someone with, diabetes or COPD not to take their medication because they should just work harder at it. So we shouldn't be doing that with addiction either.
Brandon Marshall of the Governor's Task Force agrees.
Simply what we know from decades of studies is that enforcing or trying to mandate cold turkey approaches, abstinence-based approaches, can fail for many, many people. And MAT is really the best we have. It's a gold standard treatment, and it works. And studies around the world have shown that. People regain functioning, they get their normal lives back, they can go back to work, they can re-engage with their family.
The list of experts we interviewed who believe that stigma is problematic to overcoming Rhode Island's opioid problem is long. Tom Coderre was recently hired by Governor Gina Raimondo to lead the opioid response and serves as a senior advisor.
People don't want to admit that they have a problem, and mainly because of the negative public attitudes that exist around addiction and recovery. We're seeing some of that change, but we still have a long way to go as a society. We really moralize people who have addictive disorders. We need to treat addiction like any other disease. We need to treat this with a public health response, not a moral response, not a criminal justice response.
Coderre understands that stigma because he once lost everything to addiction: his family, his friends, his job, and his seat in the Rhode Island Senate.
People don't realize the power of those substances, and I didn't realize the power of those substances at the time. And I became addicted, and my life very quickly started this downward spiral. I didn't know it at the time because, as you mentioned, I was an elected member of the state senate at 25. I thought that I was invincible, right?
He soon realized that invincibility was an illusion. In 2003, following an arrest due to his addiction, Coderre was faced with a decision: go to jail or get help. He chose treatment, and this time was successful, and has been in long-term recovery for more than a decade. He eventually made his way back up the steps to the State House and into Rhode Island politics, something he never thought possible.
What I found when I showed back up here, to my surprise and to my delight, was the opposite happened. My former colleagues ran to give me great big hugs and welcome me back and tell me how good I looked and how good I was doing and how proud they were of me. And so those fears I had were shattered immediately when that happened. It was amazing.
Not only has Coderre returned to politics locally, serving as chief of staff to former Senate President Teresa Paivaweed, he also worked for the Obama administration as senior advisor for the Substance Abuse and Mental Health Services Administration, better known as SAMHSA. But back home in Rhode Island, he continues to work diligently to find solutions. One idea that came out of the task force is the Safe Stations Project.
Every fire station in Providence is now a place where somebody can present themselves if they're having a problem with their addiction, and within 15 minutes, they'll have their vitals checked, they'll make sure that they're not in any immediate danger, and then they're connected with a recovery coach who can help them navigate what sometimes is a cumbersome system that's outside of the regular healthcare system, but help them navigate so that they can get into the right level, they can get a diagnosis of what level of care they need, and then get into that level of care immediately.
We spoke to acting EMS chief for the City of Providence Fire Department, Zachary Kenyon, who modeled the program after a similar one in New Hampshire. In just a year and a half, that program had over 5,000 people come to the stations seeking help. And Kenyon hopes that over time, Providence will have similar results.
You don't have to be a Providence resident, as I said. If you live in Woonsocket, if you live in Fall River and you want help, you come to us. We anticipate at some point we'll probably be averaging 4 to 5 people every 24 hours. And that's a lot of people. You walk that out over the course of the year, we're helping 1,600, 1,700, maybe more, change their lives. And that's really what we want. We just want the ability to connect you with somebody that can make a difference and put you on a different path.
Kenyon is a 16-year EMS veteran and has administered naloxone hundreds of times. It's because of those experiences that he knew something had to be done.
You try to talk to that person and get them to understand they need recovery or they need to change their habits or they're going to die. And you can tell them that straight out, and then less than 24 hours again, you're doing the same thing with the exact same person. That's mentally tough on the people who respond to those runs. It's hard to do that over and over again, and you feel a frustration, not only for, I guess you would say, a system, but you feel frustration for that person, because as firefighters, we're designed to help people, and you almost feel like, yeah, I've saved this person's life, but did I really help them?
Kenyon says while there are many times when he believes the system has failed, there are glimmers of hope.
I've seen it with some of the people I've had that I've picked up on a regular basis with other issues. Come up to me out of the blue and say, hey, guess what? I just got my first apartment. This is a gentleman that's 40-something years old who had an alcohol issue, came up to me. He was now volunteering at one of the homeless shelters we bring other people to, and said, hey, Cap, I just want to tell you I got my first apartment for the first time in my life. I've just paid my own rent. I want to go back to school.
It's pretty big.
Yeah.
Right?
Yeah.
To know that you did that.
Yeah.
The collaboration and hard work just might be paying off. In 2017, following years of steady increases, accidental overdose deaths in Rhode Island declined. There were 323 deaths last year, down from 336 in 2017, which is about a 4% decrease. And while those numbers are encouraging, more work still needs to be done. There are 2 pieces of legislation being considered this year that many hope will keep the ball rolling. One of them addresses the soaring number of deaths due to fentanyl.
Now we do have a test that's being used in the community, but it hasn't been spread wide enough to have an impact.
The other piece of legislation is more controversial. That is, an involuntary commitment for 72 hours. But there are legal barriers to that as well. Miller says they are trying to incorporate requirements that must be met before committing someone, such as a person's history of overdose and the number of saves by Narcan. Brandon Marshall, a member of the task force, isn't sold on the idea.
I'm not convinced that the hold in and of itself is likely to be effective, maybe in rare circumstances, but I think that what we need to focus our attention on is that handoff, that referral process from hospital back into community. I think that's where we're likely to see a bigger impact.
And back to the life-saving drug Narcan. This innovative idea is much like the defibrillator boxes you see in public buildings. The nalox box provides a layperson access to the drug in a public setting. Dr. Jeff Caprero, a pediatrician at Rhode Island Hospital, helped create the nalox box thanks to a mini grant from the Rhode Island Department of Health. As of April of 2018, there were 47 boxes placed around the state, and he has requests for another 48, including orders from other states.
I think when places like businesses start coming on board, or municipal buildings, it's a statement that we care about our community, we care about this epidemic. Hopefully this thing will never have to be used, but if it is, we might have saved somebody on our premises.
Saving lives and getting people into recovery are the goals of those working to combat this epidemic. But Narcan alone isn't going to do that. Access to care is key, but many times the cost of that care is a barrier. In an encouraging sign of the times, Blue Cross and Blue Shield of Rhode Island recently announced that in 2019, co-payments for mental health and substance use disorder office visits will be on par with primary care office visits, and it will no longer require prior approval for any in-network substance use disorder and mental health services. In the end, it comes down to determined communities coming together to find solutions that can provide hope and optimism to those who struggle with opioid use disorder.
I'm back at it, I'm here, and I have a reason to wake up every day and, actually commit myself to something.
It wasn't 11 years ago, there was none of this. I'm so happy to see, but unfortunately, it's taken all these lives in order to bring this to the surface. It's always been there.
This affects everybody. And so people are going to watch and they're going to think about the person in their life that's going through this right now. And I want them to be able to know that there is life after addiction, that recovery is possible for everyone.
For almost 80 years, Blue Cross and Blue Shield of Rhode Island has been proud to partner with community organizations to promote a healthier Rhode Island. Blue Cross and Blue Shield of Rhode Island. It takes a team.